Hello, and welcome to this DeSera Clinical Education Multi-Specialty Podcast. This episode features Dr. J.H. Shubrook, Professor and Diabetologist, Department of Clinical Sciences and Community Health at Touro University, California, College of Osteopathic Medicine, and Dr. Chrisopher Weber, Bariatric Services Medical Director at Ascension, Wisconsin, Obesity Medicine Director at Ascension Columbia St. Mary's Bariatric Center, Trustee at Obesity Medicine Association, and Adjunct Assistant Professor of Pediatrics at the Medical College of Wisconsin. They join us today to discuss the latest advances in managing patients with overweight or obesity and their strategies for integrating new evidence on obesity care into your primary care practice. This episode is part of a larger educational program titled Overcoming Obstacles in Obesity, Translating the Latest Evidence into Primary Care Practice. For more information on Drs. Shubrook and Weber, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
Welcome to Translating Evidence into Primary Care Practice, the Year in Review podcast. I'm Jay Shubrook, family physician and primary care diabetologist at Touro University, California. I'm here with Chris Weber. Chris, tell us about yourself.
Sure. Thanks, Jay. Happy to be here. My name is Chris Weber. I'm an internist and pediatrician and obesity medicine specialist. I serve as the medical director for Ascension, Wisconsin's Bariatric Services. And I also sit on the board of trustees for the Obesity Medicine Association and the Obesity Treatment Foundation, as well as the Wisconsin Obesity Society.
This has been a really big year in the obesity space, and there's so much going on. So I think maybe I want to highlight some of the kind of milestone things that, from your perspective, that have happened in the past 12 months. What would you call out first?
Yeah, well, first, like you just said, there has been so much going on. I'm in this over my eyeballs every single day, and it's hard for me to keep up with things. So I think this discussion will be fantastic, gearing it for our audience. In primary care, you're on the front lines. What are the highlights over the last year? So one thing that I like to start with is the Lancet Commission. So obesity, there's been a lot of work done to define obesity as a disease. Many medical organizations have defined obesity as a disease. What the Lancet Commission set out to do was look at BMI and see how helpful it is. I think most of us understand there are some issues with BMI. It's not the best tool to diagnose obesity on an individual basis. So what they did is you use BMI as a screening tool. And if it suggests obesity, then you look at a different measure of excess adiposity. So is that waist circumference, or if you have access to a DEXA scan or bioelectrical impedance, some other way to look at excess adiposity. And then once you confirm the excess adiposity, then you look for weight-related medical conditions. And then the terms that they use were preclinical obesity and then clinical obesity, once you have weight-related medical conditions, diabetes, high blood pressure, those sorts of things.
Yeah, and I think what I really liked from that was that there are multiple ways to define obesity. And so regardless of your resource area, it could be as simple as your BMI and a waist circumference. It could be these other things. So you don't have to have all this fancy machinery. We really want to recognize and quantify obesity earlier. And the BMI, while it is objective, it is imperfect. And so I do think focusing on those other anthropomorphic measurements and coexisting conditions really makes a big difference. And boy, what a change to preclinical obesity. What's that mean?
So preclinical is when you have excess adiposity based on BMI for screening and then the other measurements that we mentioned, but you haven't yet developed diabetes, high blood pressure, sleep apnea, those sorts of things. But you are at higher risk for those. So it's an important time to increase screening for those other medical conditions and start working on prevention of further weight gain.
Yeah, and for us in primary care, when we think about the challenges of trying to do disease prevention, not just disease treatment, this is an opportunity to put a name on something and say, hey, I'm worried about you. I think you're at risk, and this is why. And let's get on this now. Let's not wait till you have hypertension. Let's not wait till you have liver disease. And of course, that's really best practice, right?
Well, absolutely. And, one concern when the report first came out was that, well, are we going to wait until someone has clinical obesity to start treating and say, well, you only have preclinical, so let's not treat yet? And I think, no, what you said is absolutely right. Diagnosed with preclinical, That doesn't mean you don't treat, right? I mean, yes, you do the lifestyle stuff, but if your assessment as a clinician is you have preclinical obesity, but you're at high enough risk to progress, you can consider treatment at that time as well, including pharmacotherapy and other things.
Yeah, and I think that's part of the exciting year. I think for sure we all know that in primary care, therapeutic lifestyle modifications and treatments are always going to be central, right? So getting your team, making sure you have people who can help advise the patient on nutrition, moderate physical activity, those things and removing toxic foods. But we have a lot in pharmacotherapy space now. And I think quite honestly, it's a little bit happening so rapidly, it's sometimes hard to keep up. So as you think of like key pharmacotherapy changes that have occurred or in the very near horizon, what are some of the things you'd want to call out as kind of things that primary care clinicians should know about?
Yeah, so what I'd start with are obesity medications that are already out there. They're already FDA approved. What's new with those? And then I'd love to talk about the pipeline stuff as well. But as far as things that are already out there, so semaglutide. We know semaglutide's approved for diabetes treatment and obesity treatment up to 2.4 milligrams. So there's the Step Up trial that looked at it at a stepped up dose, so up to 7.2 milligrams, all right, and showed even greater weight loss. It was somewhere approaching 20% weight loss. And one thing that's interesting that I love with how much study is going into the GLP-1 containing medications and obesity medications in general is that we're really learning a lot of nuances about these medications and personalizing them. So I mentioned that with this study because the participants randomized to 7.2 milligrams. A lot of them didn't get up to 7.2 milligrams because they didn't need to. They had adequate weight loss at lower doses. So not everyone, at least in this study, required that 7.2 milligram dose. So kind of personalizing things is a theme for a lot of the studies this year.
Yeah, and I think that's so important. And so, we're seeing medicines that have multiple benefits. And so, for example, semaglutide has a weight loss indication, tirzepatide has a weight loss indication. And maybe clinicians know these meds from diabetes, but you don't need to have diabetes to use these medications. They have indications for weight loss alone. And hopefully you're familiar with them, and hopefully you're aware that we have plenty of years of data in chronic disease management. But there's some exciting things coming let's start with those two medicines, then we'll talk about some new ones. With semaglutide and tirzepatide, we're starting to see some extra glycemic and extra weight benefits. So what's your favorite one of for those two medicines?
Oh, my favorite. Oh boy. One that really just changed our world was when semaglutide was approved to reduce someone's risk of major adverse cardiovascular events, right? Because that cardiovascular outcome trial showed that we weren't just, making the number on the scale go down. We were preventing death, right, from heart attacks and strokes in certain high-risk people. So that was a game changer. And it's interesting. So this is still being sorted out, but it's fascinating that when you look at the amount of weight loss that people had with semaglutide and when they started getting the benefit, the reduced risk, it happened before what we can normally consider clinically meaningful weight loss. That suggests, is there something else going on besides just the weight loss decreasing your risk for cardiovascular events? And so that's a theme with some of the other indications as well: fatty liver disease, MASLD, MASH, those sort of things. There's something else going on besides just the weight reduction. And then interestingly, talking about the liver disease, the FDA approval for that with semaglutide didn't even include a BMI, right? So any weight, as long as they had the, met criteria for the liver disease.
And I think when you're talking to patients, these are some powerful messages. Hey, I want to help you address excessive weight or adiposity, but if we're using certain pharmacotherapy as part of a comprehensive plan, we actually can reduce your risk of dying of a cardiovascular event. We can actually show benefit for MASLD and MASH. We have benefit for obstructive sleep apnea. And so I think patients often like when there could be multiple benefits. And of course, it's not just the number in the scale, as you said. We want people to live longer and be healthier. And so when we start seeing these extra benefits early, that's a powerful message.
Yeah. And boy, this is about the longest I've ever gone speaking without bringing up insurance coverage. So I'm going to do that now, is get a little uncomfortable not talking about it. When you start having these other indications, it's a lot harder for insurance companies to not cover them. There's still a lot of, we all know, bias and stigma when we're talking about weight alone, but you're seeing all these other health benefits. We're all very hopeful that that will improve coverage for our patients who would benefit from these.
Yeah, I find that when I'm writing these medications for any of the indicated conditions, I'm always going to write that in the SIG so that it's very clear what it's for. So when we're doing a prior authorization, it's easier. And I think we also need to be better about our documentation and our notes. So if we're treating someone with obesity, we should actually be saying, what have we done? What has the person done ahead of time? So when we're trying to get coverage, it's clear that this is something we're using for a targeted indication, especially when these medicines can be expensive. And so I think highlighting the long-term plan from your documentation and including details in your SIG, for me, have been very helpful. Any tricks you want to share?
Yeah, absolutely. You be as thorough as you can, and practice, right? I mean, in my healthcare system, the teams that do this multiple times per day, they tend to have more success, fewer denials. It's tough. It's tough in primary care when you're doing maybe a few a week just to get the hang of it and know all these ins and outs, which is one of the biggest frustrations, I think, for a lot of primary care providers who are trying to use these medications, all the administrative barriers that make it difficult.
Yeah, and I think when I'm talking with patients, I often highlight about where their weight is, maybe where we want to go. But I think it's really a challenging conversation because I think many patients may have an unrealistic expectation or expectation over time. How do you communicate now that we have agents that have substantial benefit, what your weight loss goal, shared goal with them would be, and how you're going to help them get there?
So people ask this all the time, what should I weigh? And so this is a common question. And I always initially respond, this is going to be an unsatisfying answer for you because it's broad. All right. So this is, I'm sure you could ask 10 different obesity medicine people and get 9 or 10 different answers on what should happen. But I always start with 5% weight loss, okay? Because that has been shown to be clinically significant. That's when we're looking at the weight alone, right? Now, some things take more, 10 to 15% weight loss before you start seeing improvement, but those lower percentages, cardiometabolic parameters improve, your dyslipidemia, hyperglycemia, those sorts of things. Another rough marker I use is what do we expect from clinical trials and these medications? And so I'll say that, okay, if we're talking about semaglutide, I expect you on average to lose about this much. Now, what's interesting, there's been some studies this past year on real world pragmatic studies, right? So clinical trials are very well controlled. This is what we expect you to lose when we're checking in on you every 5 minutes. But when you're out there living your life, what actually happens? And some of these studies, so they looked at this with semaglutide in particular that I'm familiar with, it was comparable. Now you have to be careful comparing retrospective studies to prospective clinical trials, but the percent weight loss was still quite good in real world studies. There's a long answer to your question. But then the other thing, and this is kind of, I think, what we're getting at here is that percent weight loss, is that number as important when you're seeing all of these other health benefits? And I tell someone, okay, in this trial, this medication maybe caused a little bit more weight loss, but this one had better evidence for cardiovascular protection, and you are high risk for cardiovascular protection. It's a tough conversation because of how the number on the scale has been ingrained in our mind as a society over decades. I think most people's, in my experience, initial response is, I want whatever's going to get me the greatest weight loss, because you will get some health benefits as the weight comes down, but it's a more nuanced discussion. And when we get into some of the other studies from this year, like people have certain genetic conditions, or there's some studies on menopause, this is getting really personalized, and it's much more complicated than just that number on the scale.
For sure. And I like always when I'm speaking to my patients to have set a small goal, that maybe that 5%, and say, hey, we're going to work on this. This will take time. We'll need to do multiple things. And often when because we know with at least with semaglutide and tirzepatide, we can typically get greater than 5%. They're very happy when we exceed that 5%. And I think, like you said, you can see biochemical changes on their labs and things at 5%. So there's that kind of response that they see a change, even if it's a smaller change in weight, and we see a change, and we know, of course, we're making a difference in their overall health, right? And I think that's important.
Well, and you're absolutely right. It's so important to set the expectations up front, because people know they don't know the clinical trial data, right? They know what their experience has been with weight in the past. They know what their friends' experience has been in the past. So I like to find the closest intersection between our expectations and their expectations so that, like you said, people are pleased with the results, or when they hit those milestones, that can be motivating. Absolutely.
Yeah, and I think one thing that you highlighted, the getting coverage and costs, and that is a real world issue for most of our patients.
Mhm.
There is some early data that there are economic benefits for these agents. And I think that's important to recognize that sometimes they have been shown in some of the studies to reduce hospitalization. They've also shown the reduction in cost and progression from a prediabetes state to a diabetes state. And those things add value when you look at population health. So I think that's an important part. So you mentioned something I want to really make sure we call it out. So the existing medicines that we're familiar with are starting to show some new data and maybe new doses. What would you highlight on the latest and greatest of, the current, let's say, semaglutide and tirzepatide that you've seen over the past year?
So we mentioned earlier the step up trial with semaglutide, so higher doses leading to a greater total body weight loss. But then, I want to mention tirzepatide. So there are, again, looking at personalized medicine here, there's MC4R, melanocortin 4 receptor, involved in appetite regulation, and a deficiency in this receptor can cause obesity. And so what they did in the SURMOUNT-1 trial, that was a study looking at tirzepatide and percent body weight loss, they went back and looked at participants who had a deficiency in this receptor. And it was 32 patients, so not a huge number, but the response to tirzepatide was about the same as people who did not have that deficiency. So that's very interesting. I get in these conversations with patients who have all sorts of underlying medical conditions. You say, wow, is this medication going to help or not? And boy, I mean, almost across the board, you get some benefit. And this is just one specific example where this genetic deficiency can be adequately treated with an existing medication.
Yeah. And I'm thinking about, as I see in my practice, the emerging problem of child and adolescent obesity, as well as even pre-diabetes. So I have been really excited to see there's data that is emerging for using these agents even in childhood. And so I think, we looked at some of them in the diabetes studies, but there certainly was an obesity trial as it relates to liraglutide and showing benefit in pediatric patients. I assume as MedPeds, you also have a similar experience with that challenge.
Yeah, absolutely. I mean, as of now, there's no FDA-approved obesity medications under 12 years of age. So the liraglutide study that you mentioned, it goes down to age 6, so from 6 up until 12, and it showed comparable results to what we've seen in other groups. That's some exciting stuff. Tirzepatide is being studied in adolescents, so not as young as the liraglutide, but younger than currently approved. So more of this is coming, and it'll be helpful for our patients.
For those primary care clinicians out there, I want to make sure you don't miss the fact that we do have agents approved down to age 12. And certainly this is something we've been able to get covered in California when you're doing the right documentation. And boy, that to me, that's really moving upstream, which I think is very important when we look at this. So Chris, I want to make sure we have time to talk about some of the emerging things. It seems like that we're just opening the door to a whole new world. What are you most excited about agents in the pipeline or emerging agents?
Yeah, it's having a bigger menu. As we've talked about many times already, the personalization, there's nuances to these medications, right? There's some things that I hear from my colleagues who don't do this every day. Oh, this GLP-1 had this study that showed this result, so it must be all GLP-1s, and that might not be the case. So we're learning more about these nuances. So just to mention a few of the newer medications, more oral options. Okay, there are many more oral options coming out right now. So there's already an FDA-approved oral semaglutide, just at a much lower dose for type 2 diabetes, but it is with the FDA right now at a higher dose of semaglutide, 25 milligrams daily oral medication, and the results are comparable to the subcutaneous weekly injection. So I think that will be nice for patients who prefer a pill over an injection, which is to have an oral option that is that potent will be beneficial as well. And then the side effect profile is very similar as well. So the oral route versus subcutaneous, very similar side effect profile.
Yeah. It's an exciting time, and I think it's important for us, for our patients, to know that we're going to have options for them, and we can work with them individually, which I think you've highlighted. So I have a lot of patients that have questions about safety, tolerability, and I think it is important. These are potent agents to do pharmacological effect on the incretin-based hormones. So what are some strategies that you use with your patients as you're initiating one of these agents for them?
First is counseling up front, right? I mean, because we know from lots of experience the most common side effects, right? By and far, it's gastrointestinal. Okay, nausea and constipation, diarrhea, gas, bloating, belching, those sorts of things. When you counsel someone up front and they know they take it and they feel like they're going to throw up the next 2 days, it's not great, but at least they know that that's not entirely unexpected. And then, if this is something that often resolves over time, you can get through it. Don't get me wrong. There are people who can't tolerate the medication. Nausea is so bad, they're throwing up every day. That's no good. But also to have open lines of communication. If you should be able to have someone answer the phone any time of day to help triage these side effects. And then, I have found that the community has been so helpful. So patients talking to other patients. Now, and it's just troubleshooting, right? So there's no science that says, oh, if you have a protein drink the day you take your shot, you're gonna have less nausea. But boy, I have a lot of people who say that and they tell their friends, and their friends have the same experience. But it's just troubleshooting these sorts of things. So how you set that up as a clinician, it depends on patient by patient. But that community can be very helpful as well.
Yeah, I think that's such an important point because we have such limited time, and I think multiple touch points can help. But, as you mentioned earlier, setting reasonable expectations of what you might experience as a side effect early on, that these will often go away with time, and they can be mitigated by things that the patients do. And so certainly mindful eating, not overeating. I always say this is Thanksgiving time. This is not the time to have a big Thanksgiving dinner. This is the time to, have that small plate and see if you're satisfied, because this is going to bring that satiety sense back to you. And then also, what is the exit ramp, right? And I think it's so important for people to know that there are going to be some people that just don't tolerate these agents. And if they are having severe abdominal pain, severe vomiting, those are things that they should call us, and we will certainly balance the benefit risk ratio for them. And then I guess I'm going to give a comment here, and I'd love to hear your thoughts. I also have seen a fair amount of diversity in the response to individual GLP-1 receptor agonists and dual incretins. So just because they had side effects to one, I wouldn't necessarily write the class off. I think that often switching, people can have very different tolerabilities, at least in my experience. I'd love to hear what your thoughts are.
No, exactly the same thing. Boy, I mean, that's across all the GLP-1 containing medications. I mean, I've had, for example, some with type 2 diabetes and they're on tirzepatide, like, wow, you expect a lot of weight loss with that, and they don't budge. You move them to dulaglutide, which is not an obesity medicine, it's a type 2, and they tolerate it and do fine. All right. Now, overall, I tend to see more side effects with dulaglutide compared to tirzepatide, but there definitely is individual variation.
And then as you're looking forward to trials, what are things that you're excited for? Or what are things that you think are some bright spots that are on the horizon that we've not talked about yet?
I'm also excited about new medications with a different mechanism of action. So we know about the GLP-1s, there's GIP, there's glucagon agonists coming, and then quadruple agonists as well with IGF-1. And then the amylin agonists as well. There are several of those in study right now showing some pretty significant weight loss. So these different mechanisms will just widen our menu for patient treatment options. And then another thing that's kind of a hot topic right now is lean mass retention, right?
Mhm.
So when you lose weight, if you're not careful, you can lose too much muscle. And so some of the newer agents are looking at specifically losing total body weight, but maintaining that lean mass. So those are fascinating early studies that are going on right now.
Yeah, and I think while we hear these many exciting extra weight and extra glycemic benefits, addiction, Alzheimer's, other things, those are all very
Mhm.
exciting. They're coming, and we will get more data. But I want to make sure we don't lose for our primary care clinicians that you've got some really excellent agents that you can use today to make a difference, not only in your patient's weight, but also in their cardiovascular risk, in their risk for MASLD and MASH, for their risk for other outcomes, and actually even some evidence for economic benefits. So find the one that you get covered for your patient, make sure you do the documentation, and we'll be doing right for both personal and population health.
Thank you, Dr. Shubrook and Weber, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Overcoming Obstacles in Obesity, Translating the Latest Evidence into Primary Care Practice, please click the link in the show notes. And be sure to check back regularly for more episodes on important multi-specialty topics.